Okay, thank you for joining us today for our Lutz webinar discussing transforming rural hospital financial operations. My name is Julianne Kipple, and I am a shareholder here at Lutz. Paul and I actually just celebrated our 15-year anniversary at Lutz, so have been working in healthcare since 2008. I'm excited to run through some of the topics today.
Yeah, and Paul Baumert, also a shareholder here with Julianne, and started here at Lutz in 2011 and been in healthcare for over 25 years.
Okay, so today's agenda, we have four main topic areas that we'll work through today, but we do want to encourage you guys, if you have questions throughout the presentation, you can enter those into chat. And we'll try to stop and address those as we can throughout the presentation. We'll also have some time at the end for questions. So you can always save the questions till the end of the presentation, or if you just want to reach out to us separately, you have our contact information. We'd be happy to go through any questions you have outside of the webinar. So like I said, the agenda for today, we're going to be leveraging cost analysis to pinpoint profitability leaks. Then we'll be taking a look at trying to identify potential savings through the Medicare cost report review. Then we'll touch on grants, funding, and reimbursement strategies that are unique to rural facilities. And then we'll close with insights on budgeting, forecasting, and long-term planning. So about Lutz. Lutz was founded back in 1980. We are headquartered in Nebraska, have Midwest values. We are up to over 370 employees, and we have the Lutz network here. So we, started as an accounting firm, but we have, Lutz has grown throughout the years to add financial planning, investment services, merger and acquisition services, along with a talent division and a tech division. So we are a business solutions firm. So if you ever have needs in any of these areas, please feel free to let us know. And Paul, I will turn it over to you to talk about the first agenda item.
Okay, great. Leveraging cost analysis. One thing I wanted to start with is internal controls. We'll get to kind of what the analysis looks like, but one of the things I think every rural hospital should take a look at is their internal controls as far as their purchase approval process. We do find that there tends to be duplication. Maybe we're not getting the best price. Sometimes you order something and it comes back at a different price. How do you prevent that type of leakage? So I would recommend that you kind of review your internal control processes for purchases. If you haven't done it so in a while, and continue to kind of do an internal review, internal audit related to those processes on at least an annual basis to make sure that your processes are holding up and are catching things that you can to help reduce costs. So the purchase approval process, just assures that the procurement is authorized, documented, and precise to prevent fraud, waste, and unauthorized spending. So I know that there are times where you purchase something and it might be a duplicate. Someone else in the organization purchased the same thing or the same type of service, so you might have some duplication. So just make sure that you have a formal approval process and that you're checking it. Segregation of duties is also very important. So we want to make sure that the staff requesting a purchase is not the person approving, receiving, or paying the invoice. I know it's difficult sometimes in a smaller organization to do this, but to the extent that you can, you don't want the same purchase, the person that is requesting the purchase, approving the purchase, receiving it, and paying the invoice. Try to segregate it as much as you can. And then I think it's always important to have purchase amount thresholds. So whether it's, the person in the staff in the department has the ability to purchase something, request a purchase at a certain dollar level. There's a certain amount that has to go to their supervisor. And then organization as a whole, large purchase Equipment, for example, a new CT machine probably has to go through board approval, probably in type of a capital budget. So make sure that those thresholds are set, make sure that those are followed. And again, I can't stress enough that you at least review this, and also kind of do an internal review to make sure that you're following those processes. I would also recommend, you're going to have new staff come on a regular basis. This probably needs to be part of your regular onboarding for new staff, and your probably annual staff education as well, reminding them of kind of your purchase approval process.
Yeah, and we've seen some, I think, improvements the last several years in some of the general ledger software companies, kind of expanding that threshold process. And you can add like an internal control into your general ledger system, your software system, to make sure that you're following the proper protocols regarding those thresholds and those approvals. So making sure to check with your software company to see if that's something that you can use the system for.
Exactly. As far as, just not going to go through this in detail, but it just gives you a list of, what you should be doing. Make sure your vendor list is up to date. You don't want to be sending checks to an old vendor, or a fictitious vendor. Make sure you have pre-numbered purchase orders to ensure all transactions are tracked. And then the three-way match, which makes sure that accounts payable matches the purchase order with the receiving department and the vendor invoice. If you're doing that, you might be doing that through your software, but that's a good way to make sure you're not receiving something that you didn't purchase or there was not an approved purchase order for. Conduct regular audits of process and controls we talked about, annual staff training and review, and then budget versus actual comparisons by department to identify outliers or unusual activity and explanations monthly. So this is more probably of a finance, but each department will have a budget. They should be able to explain and hopefully explain why they're over budget in certain areas. Other than staffing, what we're more talking about is contracted services, purchase of supplies, other expenses for each department. But make sure that you're reviewing those budgets, the department heads are reviewing those budgets, and there are explanations. You might be able to catch some things in that budget versus actual comparison on a month-to-month basis, and then make recommendations or identify things that you need to change. So on purchase contracts, this is usually a high dollar expense item for hospitals. So just making sure, really what we're trying to do is keep the vendors honest, making sure we're getting the best price, so multiple bids. I know you get comfortable with using the same people that you like or the same vendors that you like, but if you don't go out, you're not going to probably go out bids every year, but at least every 2 to 3 years, just so you're getting the best price. It gives you some leverages also to push back with your current vendor to maybe get a better price on certain things. And then, review your terms. Make sure you understand if you want to make a switch, when can you switch? Is there a penalty? And what's the timing? And the other thing I think I'd recommend is all these purchase contracts that you have, maintenance contracts, everything that you have, you're organized, you have an actual list of everything, you have those contracts, and I'd recommend having them electronically saved somewhere and have it summarized. So you know what contracts you have, what are those contracts for, and when do they expire, when do you need to renew. That gives you an idea of what you can look at for cost savings and things you can do, and not get stuck in a contract for another year that you want to get out. Staffing, contract labor, and service contracts. So, one of the major costs, probably 60% of your costs in a hospital are, salaries and benefits. So monitoring the staff levels, making sure that there's no unnecessary overtime, reducing. I know contract labor is very expensive, and I know it's a goal of every organization is try to hire someone versus having contract labor, but trying to reduce that as much as you can through scheduling. Again, going out for multiple bids for contract labor if you can. Constant recruitment, which I know everybody's doing, but to the extent that you can, you want to try to think through, what positions do we have? What is contracted now? What opportunities we have to hire internally? We'd always recommend that if you're not doing employee satisfaction surveys, that you do them. Usually you get some good feedback with that, things you can do differently. How's the culture in your organization? Is there the ability to hire more staff versus contract if you can? And then as far as the service contracts, we want to make sure that we don't have any duplication, meaning we have multiple contracts for the same service. We're purchasing through different vendors the same type of product or service, and trying to get the best price there. So again, I think it's very important to be able to make sure you understand where all those contracts are at, when the due dates are, that kind of documentation will help you prevent duplication as well. Service line analysis. So kind of spent a lot of time on kind of internal controls and making sure up front what you can do to get the best price and make sure you're organized. And now we kind of get into more of the detail analysis. So trending revenue and expenses over time to establish benchmarks and compare to actual. So that's a little bit of budget to actual. When you go through your monthly budget analysis. But having a trend line for expenses compared to revenue kind of helps you determine what's going on in the department. Sometimes what you'll need to do is if you have the emergency room, but you don't have the professional fees in there, kind of grouping those professional services with the facility lines helps you identify what the total cost is. Cost report can be a really good tool as well. Kind of looking at your cost to charge ratios. We'll talk a little bit about matching as we look at the cost report analysis. But those cost to charge ratios will tell you a little bit of a story of where your cost is going in lab or radiology. What's your cost to charge ratio over the past 3 to 5 years? What's the reasons for the increase or decrease? Obviously, the lower the cost to charge ratio, a lot of times the better margin you have on that department. But where's your trend? I think every organization is a little bit different. Cost to charge ratios usually are within a range, but you really need to kind of get into the detail of your facility and see what that trend is with your cost to charge ratio. And then with that analysis, that service line analysis, looking at revenue and FTEs and volume, what we would call revenue drivers, your volume or your revenue drivers compared to your FTEs, where is that at? That actually, that'll drive 60% of your cost in that department with salaries and benefits. So getting a handle on what that trend looks like, I think is very important to try to identify potential cost savings and opportunities. Net revenue, that's difficult sometimes to get to the department level. A lot of times when you get reimbursed, you get reimbursed for an inpatient stay or you get reimbursed for an outpatient service, and it's multiple departments. The revenue and the expenses are in different places. You can do kind of an estimate on that. It's difficult to do, but it's valuable if you can get it right. But I think to start, the best thing to do is trend your expenses by department, trend your revenue and see what that relationship is, and really look at your cost charge ratios. If you can group those like you group your cost report to get an idea of what's happening over the past number of years and what you should expect going forward. Lastly, we're in the age of AI. automation tools are out there. You're going to see more of them. I don't think a lot of the facilities we work with right now are using AI. I know it's coming. In the expense analysis, there will be tools out there. My recommendation is just be aware of that. Ask the questions. You'll probably get bombarded with vendors here very shortly with these great tools that you can use to cut costs. I don't know, we don't know exactly what those costs are going to be to have those tools, but they're coming. So don't shut them out. I would say that we're probably in this industry, we're probably going to be using them in the next 5 years. So just be aware of what's out there, what's available. Does that make sense to look at for your organization, because they're coming and they will be available. And I would say that there are going to be some solutions that are going to be beneficial. Keep an open mind and identify any AI or predictive modeling that may help you identify cost savings.
Yeah, and we'll touch on this, but Microsoft has a specific rural program that has some opportunities, so we'll touch on that here later in the presentation.
Great, thanks, Julianne. Okay, the next, any questions yet? Okay. Potential savings through Medicare cost report review. One thing we want to make sure in your cost report is that we're matching revenue and expenses, the revenue on the trial balance and the revenue and the usage report. So the expenses match the revenue. A lot of times you're going to have charges in different departments that you may have to reclass on your cost report. You may have costs that you need to move on your cost report. You're going to have expense and revenue classifications that take place in the cost report, but that's probably one of the main things that you can do internally. And working with your cost report preparer is to make sure that you're at least matching revenue and expenses to make sure we're getting the right cost reimbursement. The other thing up front is making sure those expenses are going to the right department. When we prepare cost reports, we look at the prior year, we look at the current year and what the expenses by department and the revenue did. Usually, expense goes up, revenue goes up, but we will find certain situations when we review that, we've got a physical therapy department that their costs went way down, and the occupational therapy department, their costs went way up. Well, what we find out is the invoice, the therapy company has both PT and OT, and we've posted the wrong expense to the wrong department, so we're not getting cost reimbursement in the right place. Now, that cost reimbursement, when you correct it, may be better or worse. But what we're just trying to do up front is get the correct cost reimbursement by matching revenue and expenses. So that's very important to make sure that's taking place. I would, make sure you're training whoever's entering in the accounts payable, that we're coding it to the right department. We're not coding it to, a non-reimbursable cost center by mistake. And obviously, if we're reviewing budget versus actual, we may be able to catch some of those things. But your cost report preparer is also looking at those things as well. The other big impact that on the cost report is your statistics. So days and visits. If you think about it from a standpoint, if your days and inpatient go up, your cost per day goes down. So we want to make sure that our days are accurate, that we're not inflating the days. We're making sure that our Medicare days, our total days are correct. Our swing bed days and our total swing bed days are correct, because that can have a significant impact on the reimbursement, especially for a hospital that sees either a significant increase or decrease in days. You can see a big shift in cost reimbursement. So making sure those days are correct, you may have to go back. You're going to have a stat. Everybody has a stat sheet monthly and year to date. But are we kind of verifying that at the end of the year through your revenue and usage? You might have had some changes. You might have had an inpatient that got admitted, but then it got switched to observation. So are we making sure that those corrections are being made? Your B1 stats, which is basically your step down process on the cost report, the stats that are used to allocate your overhead, like depreciation, laundry, nursing administration. So have those been updated and are accurate on an annual basis? Are those being reviewed? A lot of times we'll do a cost report and the square footage hasn't changed in 3 years. We know that's probably not correct. There's always seems to be some changes that take place. And then make sure if you do make some major changes, as far as you do a building project or you have an addition, that you're tracking those changes and you're making sure that when you're done with the project, you're identifying where that square footage is now, because that will have an impact on your overall cost reimbursement. Many of our hospitals, and mainly because they don't have a nursing home attached, they've moved to a simplified method, which puts a lot of cost. For example, it uses days for dietary and days for laundry instead of allocating laundry by pounds or dietary by meals. That has we've seen an improvement in overall cost reimbursement because we're shifting cost from other ancillary departments like radiology and physical therapy up to the acute department, which typically has a higher Medicare share, so we're getting more cost back in acute. But if that's something, if you don't have a nursing home and you're not using the simplified method, it might be something to take a look at and see, if you do a 3-year analysis, if it's overall beneficial. We've done not a lot recently, but I think in the last 10 years, we've changed the hospitals we work with to the simplified method and seen a benefit there. If you're not using this simplified method, is there a different stat that you could use that would identify better cost reimbursement? Basically, what you're trying to do is shift costs from a lower Medicare share department to a higher Medicare share department. Housekeeping is a great example that we've seen, switching from square footage, which is the typical statistic, and moving it more to a time study. If you just think about how much time does the housekeeping staff spend in the acute swing bed department compared to other departments, normally they're spending more time in the acute department. So that time study will allocate more costs to the acute department, which will bring you more cost reimbursement because of a higher Medicare share. So looking at the statistics, number one, making sure they're accurate and correct. And number two, are we identifying any other statistical method that we can use that would get us, more accurate and more Medicare cost reimbursement? Business office or cost allocation with a nursing home. So if you do have a nursing home, there are some things you can do if you haven't already. A lot of hospitals that have nursing homes will separate out a different cost center for the business office, which then can be allocated by gross charges, which then usually puts more cost into the hospital versus the nursing home. Those business office costs are normally what would normally be in the administrative department, which is allocated based on total cost. When you split those type of business office costs out and use gross charges, you're usually getting better reimbursement because we're shifting cost away from the nursing home and back to the hospital. Same thing for data processing or IT costs. If you have a nursing home, the stat there is the number of terminals. So you don't have a lot of terminals in the nursing home, but you do in the hospital. So we also see a benefit of taking those data IT costs because your costs in the hospital for IT systems are usually a lot higher in the nursing home. So if we can use the terminals as a stat, we're again shifting costs out of the administrative department into its own separate department and allows us to put more cost in the hospital. those are just some examples.
Then I was just gonna say, with all of the, how expensive the EHR systems are, really taking a step back and, instead of maybe grouping your EHR expense just into admin in general and doing the accumulated cost allocation on the cost report, maybe there's a different way to allocate your EHR expense, using terminals or some other allocation stat that would make sense that could have a significant impact on your Medicare reimbursement.
Thanks, Julianne. Lastly here, other things to think about that you can look at when you do a building project, for example. Medicare will allow you typically to be able to separate out new construction projects in a separate cost center. You have to request that to Medicare 90 days before your cost report end date. Then they have 60 days to respond, and then you could potentially use that for the next year. But a lot of times, depending on what you're remodeling or what your new construction add-on is, if that square footage is heavily in the acute department or other departments that are heavy on the Medicare side, a lot of times if you split that cost center out for the new project, you can get more costs to higher Medicare departments if that's what you're remodeling, for example. And then by using that square footage only for that remodel project, you take all that additional depreciation cost. You have your old depreciation and your new depreciation, and you put all that new depreciation to higher Medicare share departments. So something to consider there. Time studies and contract reviews. Now in the age with the rural health clinics and the all-inclusive rate, the idea was to maybe shift costs more to the emergency room. What are we contracting out emergency room call services? Does our staff do that? Are we doing a time study? Making sure that time study is correct. But how are we paying our providers to take call? Where is that cost going? Are we allocating it in the time study? Is it in the contract of a certain amount for call every year? So if you haven't looked at that in a while and, taking a look at the cost report and the impact by shifting those costs, that's something that you can take a look at, especially if you're already over the all-inclusive rate. We want to get costs out of the rural health clinic if we can, and move it to ER if that's an option. But sometimes you may have to look at your time studies. You also may have to look at your provider contracts. Non-allowable costs, we want to obviously try to reduce that as much as we can. Advertising is an area that advertising costs to try to promote additional volume to the hospital is not allowable. But advertising to promote a good public image for the hospital is an allowable cost, as is advertising for physicians. So reviewing where that advertising cost is on your trial balance, making sure that your cost report preparer is not excluding those costs from their cost report that's allowable. Normally, in your cost report preparation, you're reviewing those advertising accounts and identifying what it is. But sometimes you can identify some ads that are more promoting a good public image than trying to generate additional revenue or volume that could be allowable. The other thing from a non-allowable cost is unfunded depreciation. So any interest income that you earn on your general checking account gets offset against interest expense. If you have a funded depreciation account set up, many of you do, that you're putting dollars away for future capital projects, you have to request that and get that in the board minutes and identify that you have a funded depreciation in your cost report in the questions in the cost report. But any interest income gained on an annual basis in a funded depreciation account doesn't have to be offset against interest expense on the cost report. So if you don't have a funded depreciation account and you have 200 days on cash on hand, that would be a way to increase interest expense because you wouldn't have the offset. And managing that as well. How much should you have in cash and how much you should have in funded depreciation, and taking a look at that. Evaluating service lines that are not cost-based reimbursement. A lot of home health departments and hospices over the years, hospitals have decided because of the negative cost reimbursement impact, they've decided not to do home health, for example. But do you have an ambulance? You want to make sure you don't have any over allocation of cost in the rural health clinic. Are you coding all the costs, or I guess all the costs coded to the rural health clinic? Is that correct? Or should it be more general administrative costs? A lot of the cost reports that we prepare, we take the administrative type staff and cost in the rural health clinic and we move it back over to the hospital. And that's a way to reduce costs in the rural health clinic. But taking a look at, non-reimbursable cost centers, number one, making sure we're not putting costs there that belong to the hospital. And then, evaluating if those types of services, what's that impact on your overall cost reimbursement by having those non-reimbursable cost centers. And maybe it makes sense for somebody else in the community to do that because of the negative financial impact. And I know a lot of you have done that over the years. And also, I think before you get into, adding a non-reimbursable cost center, you understand what that cost report impact is as well. So, maybe it's great for the community. Maybe we can generate some more revenue if we add a non-reimbursable cost center that's not cost-based on the cost report, but what's the cost report impact? And that probably needs to be part of the analysis or the decision-making process. And then I think lastly here, with the all-inclusive rate that we've had for the last number of years, some hospitals are taking a look at the rural health clinic versus a provider-based clinic. So a rural health clinic that's on campus. Sometimes if that all-inclusive rate is a lot lower than your actual cost per visit, financially it makes sense to move it to a provider-based clinic from just a strictly Medicare reimbursement. So you might want to consider taking a look at that. The downside to that is with a rural health clinic, the patient is getting one bill. With a provider-based clinic, just like your specialty clinic, the patient will get a professional fee bill along with a facility bill, so they'll get two bills. Depending on the insurance that they have, their out-of-pocket may go up, but it might be something to take a look at in the future if that overall financial impact is very significant, especially maybe if you purchase a clinic, the physician in your community that you're renting out the space on your campus is retiring, you're going to buy that clinic out and convert it to a rural health clinic. You're going to be stuck with a lower all-inclusive rate because you haven't been grandfathered in. Maybe having a provider-based clinic may be a better financial solution for you.
Right, and then the added advantage in the provider-based clinic of being able to bill method 2 potentially for those Medicare patients.
Exactly, get an extra 15% on all the outpatient professional fees. So I'm going to turn it over to Julianne. I don't think we have any questions yet. We'll obviously have questions available at the end, but Julianne's going to talk about grants, funding, and reimbursement strategies unique to rural facilities.
Awesome, thanks, Paul. You can jump in here. So the next several slides, as Paul mentioned, we're just looking at potential grant and funding opportunities specific to rural healthcare facilities. So the first grant that we want to hit on is the Rural Health Transformation Program. I believe everyone at this point has likely heard of RHTP, but it is a moving target here by state. So we'll just run through some high-level overview of the program, and then we'll get to some more specifics on the next slide. But RHTP is $50 billion in funds allocated to approved states, which all 50 states were approved over 5 years. So there'll be $10 billion available each year from 2026 through 2030. Like I said, back in late December, they did announce awards for all 50 states that ranged up from 154 million in this first year to $281 million per state. So at this time, CMS is assigning project managers to each state, and then, we would encourage you to go out to each state's project plan and state fact sheets, which we have the links here for, to just review, each state's initiatives and which facilities can apply for which grant funding areas. So, for an example, I would say, most states have 5 to 7, state-specific initiatives that they're funding through RHTP, but maybe only 3 to 4 of those, hospitals can apply for. So it's just kind of working through each of those initiatives, understanding them, and looking at how maybe your hospital could get involved in that funding. So allowable uses of RHTP, it's really focusing on prevention and chronic disease management. There are some allowable uses to provide provider payments for healthcare services, but that is limited on a state level to 15% of total funding. It's focused on telehealth and IT infrastructure. You can focus on workforce here, but the caveat with the workforce use is that those providers that you would kind of recruit through the workforce model need to stay in rural for at least 5 years. Mental behavioral health, substance abuse, new innovative care models. Something to note here too would be capital expenditures. That is limited to no more than 20%. And one of the non-allowable uses of RHTP is any new construction. So while there are some room and capital expenditures for upgrades, equipment, and minor renovations, you won't be able to do any new construction through this program. So next steps on rural health transformation, like I said, each state's initiatives are different. So we'd really just encourage you all to go to your state's project initiatives to see if your facility can apply for specific funding. Looking at collaboration with other state agencies or other stakeholders in the area to maximize your opportunity for funding. And at this point, all of the states are in different stages of this. Like Iowa, for instance, has already had grant applications open, and they've already announced the 2026 first grant funding awards. However, most states that we work with have not, opened up their funding quite yet. So it should be something that hopefully we're getting more information on, every week, but definitely monitoring your state's RHTP website is where I'd start to get the most, up-to-date information. And then also just a reminder that this is federal funding, so there are single audit considerations, although the single audit threshold is now up to $1 million from $750,000. So just keeping that in mind as you look at rural health transformation program. Another opportunity here is MAHA Elevate. So this is from the CMS Innovation Center. So essentially what this program is looking to do is kind of supplement services that are not covered by traditional Medicare. So it's intended to support, not replace medical care received by people with Medicare. So I just checked yesterday, the notice of award is not yet issued, but they're expecting it here in early 2026 at some point. So this is going to be $100 million total with up to 30 awards expected via cooperative agreements. And really, the goal here is to elevate preventative lifestyle interventions through cross-sector partnerships and data infrastructure. So I have listed the website here if you'd like more information on MAHA Elevate. Eligible participants for MAHA Elevate are listed here. So it does include, federally qualified health centers, rural health clinics, and community-based organizations along with state and local governments. So potentially some opportunity here to review this grant opportunity. Moving on, the next grant we want to touch base on is the Rural Residency Planning and Development Program. So this one is through HRSA, and really the goal is to develop new accredited rural residency programs, including rural track programs. So you can see the specialties that would be included in this area. They're expecting 14 total awards of up to $750,000 each. And again, that is expected to be posted here in the next few weeks. And we have included that link, again, if you would like more information on that program. Lots of grants out there right now, so we'll keep moving through these. The next one is Technology-Enabled Collaborative Learning Program, also through HRSA. So it's really trying to kind of, what Paul was saying, capitalize on technology, AI, to help support collaborative learning, to improve retention of healthcare providers, and increase access to care in rural and underserved areas. So 9 expected awards here, up to $475,000. I checked again yesterday. It said expecting posted February 2nd. I haven't seen it yet, so just one that you'd have to continue to keep monitoring if you feel like that would be an opportunity for your facility. So some opioid response grants are available. There's an impact grant, which we'll talk about, and then there's a planning grant on the next slide, but both of those fall under opioid response programs, both through HRSA. So really they're trying to address, substance abuse disorder, opioid use disorder, and just trying to create prevention, treatment, and recovery programs, along with workforce development. So this is, significant awards, $750,000 over a 4-year project period, with 80 awards expected. There's no cost sharing on this one, and you do need to be in a rural service area for eligibility. And again, that post date here, hopefully in the next few weeks, with applications due mid-May. This is, again, the planning piece of opioid response. So if you feel like you're, interested in developing a program that we talked about on the previous slide, but you're just not at that point, the purpose of this grant would help you just kind of start exploring how could we go ahead and try to build something like this in our rural community. So no direct services here. This is just, again, more planning to say, how could we structure something like this? So there's 40 awards expected in this area, $100,000 for a 1-year grant there. Have not seen this posted yet, but expected late February with applications due April 27th. Moving on. So this is a grant, that I think we're all pretty aware of and have utilized, which is the Flex Trip program. Annual funding here for small rural hospital improvements. You can see the purpose there on the slides. It's run through the State Office of Rural Health. And we have included the 26 allowable investments here. So, really in this fiscal year 26, if you haven't really, looked at this yet, they're saying that you must meet some of those quality requirements before you can select another investment, which I believe is a little bit different than past years. So if you haven't had a chance yet to look at those allowable investments or those critical access hospital requirements, we have included those links here as well. Okay, so the next area is loan repayment programs. Again, you may all be aware of this, but just wanted to summarize this here for everybody on the webinar. But there's the loan repayment and then the nurse loan repayment. So both of those programs are still open through the end. Well, the one on the left is open through 3/31. The nurse program is open through 3/12. So if you're interested, it is open and you can apply for these right now. Obviously, really the idea of this is to support rural healthcare providers, by making those loan repayments to those providers. There are various programs on the left, and we've included the link there for, there's a traditional loan repayment, substance use disorder, workforce loan repayment, along with just the rural community loan repayment. So that information is all included there. And then on the nurse side of things, the nurse staff must meet certain eligibility requirements, and all that information is included in the link on the right-hand side of the screen. The next section here, this is just charitable trust and private funding. So I thought this may be helpful. There's the Rural Health Philanthropy Partnership, say that correctly. which is organized through that Rural Health Info website. So if you guys haven't had a chance to go out and look at that, what it is a listing of foundation, federal agencies and national partners that have, supported rural healthcare in the past. So, some of them are restricted by state, location, region, some are not. But we have seen, a lot of success for some of our clients, especially through Helmsley, maybe purchasing a new CT or having, other investments supported through these private foundations and trusts. So that information is there as well for your reference. Okay, so moving on here, kind of moving out of grants into other funding opportunities. This is the USDA funding opportunity for the rural health development loans and grants. So this is a popular program with hospitals, and really what it does is offers low interest loans and grants for construction, expansion, and improvement of healthcare facilities, which in rural healthcare is a high need and a high interest area for those communities. So it is population based, giving priority given on population and low income communities. Facilities can also utilize the loan guarantee program. I did reach out to USDA. They did note that the grant piece of this, they have not been allocated any additional grant funding through this program at this time. But the guaranteed loan program is, still very popular with hospitals. And that guaranteed loan program is for communities with less than 50,000 residents. So you can currently apply for this funding, and the website is listed here for your reference. Okay, so Medicaid DISH. So although this may not be for everyone, we have found this to be a potential funding source, significant funding source for some of our facilities. So just want to make sure that everyone's aware of it. But it is a federal law that, state Medicaid programs make disproportionate share payments to qualifying hospitals that serve a large number of Medicaid and uninsured individuals. So, taking a step back, what the program is really trying to do is encourage rural facilities to keep their OB programs. So that is an eligibility criteria that you have, 2 OBs with staff privileges to provide those OB services to Medicaid eligible individuals. For any of our rural facilities, obstetrician may include any physician with staff privileges at the hospital to perform non-emergency OB procedures. There are a couple of exceptions, if you serve a younger demographic under 18 years of age, or if the hospital did not offer OB services when this Medicaid DISH law was enacted back in 1987, you could still apply. It's an important area. I mean, we've had some facilities that maybe have had one OB and all they had to do is go and have a second OB and then qualify for this program. And it can be significant funding year over year for those facilities.
Yeah, and Julianne, you don't have to currently provide OB services. You would have had to do it back in 1987.
Yeah, so the exception there is if you did not offer OB as a hospital back in December 22nd, 1987, you basically don't have to follow the OB requirement. So when it was enacted, what they're trying to say is if you had OB, we want you to keep it, but they're not going to penalize you if you didn't have OB at that time. So it's an interesting exception, definitely something to take a look at if you're interested in the program. And then the Consolidated Appropriations Act that just came back, was just issued on 2/3 of 26, so just a few weeks ago. That did postpone expected Medicaid DISH cuts back to fiscal year 28. So they keep kind of saying that those cuts are going to go into place for Medicaid DISH, but they keep pushing it back. And the most recent update is it did get pushed back here in early February to 2028. Okay, the next program here is the Rural Hospital Stabilization Program. This is interesting. It is a program to basically work as a group. Critical access hospitals and rural emergency hospitals are able to apply for this. But it's basically a program you work as a cohort to help improve their financial stability by enhancing or expanding healthcare services. So if you're interested in applying for that, the application is open. They said that they will not actively be selecting new hospitals until sometime this summer, so summer of 2026. But you are able to go out and apply for that program if you're interested, and the link is on the slide. So I mentioned this earlier, this is the Microsoft Rural Health Resiliency Program. So the goal of this is to help rural healthcare facilities foster AI adoption, bolster cybersecurity protection, and then provide access to affordable solutions and technology. So, you know, a lot of rural facilities qualify for this program. There's nonprofit pricing, which has been significant savings for our hospitals that have taken advantage of this program. You can get 250 free Windows 10 licenses through mid-October of 2026. And then there's free cybersecurity assessments, training, and resources. I believe there's even some training and resources on AI and some of the adoption aspects that Paul was talking about earlier in the presentation. So if you have not checked out this program, please do so. It can potentially, you know, generate a good amount of savings for your facility, and you have other resources for you from an IT perspective. Okay, so critical access hospital specific Medicare funding opportunities. Just want to make sure we hit on these. So as a critical access hospital, one of the advantages you have is that you can bill method 2, and then you can participate in the CRNA pass-through program if you qualify. So method 2, you know, you can bill those outpatient professional services and get 115% of the fee schedule rates. The practitioner must reassign those billing rights to the hospital. If you think that you're doing method 2, we are recommending to audit those claims to ensure that you're receiving proper payment. We've had some facilities that think that they are, but weren't getting paid correctly, and maybe some providers are getting this and some aren't. So definitely would recommend auditing those to make sure you're getting that benefit. And then also, you know, the CRNA pass-through essentially allows you to claim cost report or cost reimbursement for those CRNA fees if you qualify. So that can be a significant cost savings through the Medicare cost report. And it is a calendar year election that we would, that everyone should be getting those notifications if you qualify. Ambulance, just real quick here, you know, as a critical access hospital, you know, if you meet certain requirements, you can get cost-based reimbursement for ambulance, but you do need to be the only ambulance provider within a 35-mile drive of the hospital. So there are some exceptions to that. We have seen some hospitals be able to participate in that, which can be a very large change in Medicare reimbursement for those facilities. So if you think you may be eligible, definitely look into that. And then most states have some type of Medicaid ambulance program that they will supplement the Medicaid, you know, fee schedule rates or reimbursement for ambulance services. So we just encourage you to, if you have ambulance, go out to the state websites and make sure you're taking advantage of any of those funding opportunities. You know, we've all heard rural emergency hospitals, so I just, you know, I've kept some information here that you can reference. I will say the Rural Health Transformation Program, you know, has some funding specifically for these REH conversions. So again, if you would like more information, you can definitely check out this website. You know, we have seen some hospitals participate in this program, but you know, the concern here, if you don't want to do rural emergency, is that you have to drop that inpatient care, which I know a lot of facilities, you know, are not interested in dropping inpatient care, even if it is slightly better from a reimbursement standpoint. So we have one polling question. I know we're running a little bit late here, but if you guys would like CPE, please go ahead and answer the CPE credit. And then if you would like a it's a really difficult question. I hope people are listening. So, but if you would like CPE, you can reach out to the email there after the presentation to get your CPE certificate. Okay, so thanks for participating in that poll. We'll move on to our last section here, which I think will just take a few minutes, and we'll have a couple minutes for questions. But we wanted to hit on insights on budgeting, forecasting, and long-term financial planning. The big thing here that we wanted to hit on is state Medicaid directed payment programs. So I think a lot of states are participating in this now, but what we want to make sure of when you're looking at budgeting and long-term planning is that there may be some changes to state Medicaid directed payment programs upcoming here, especially in 2028. So there's some information on how these programs work if you want to reference that. But basically what's going to change here is that most of these programs have used the average commercial rate or the ACR to kind of bridge that gap between the Medicaid reimbursement up to that average commercial rate. So that's the bucket that these directed payment programs are trying to replace. However, when one big beautiful bill act was signed back in July of 2025, it clarified that you could only get that average commercial rate until 2028. So there is a large estimated reduction in federal Medicaid funding over the 10 years. So after 2028, your multi-phase down will begin for grandfathered, versus non-grandfathered. There are some changes there, but essentially both of them are going to have to try to come back down to more of a Medicaid or Medicare rate versus that average commercial rate. So we are expecting decreases in those programs, especially starting in 2028. So I'm just encouraging you, those can be significant fundings for our facilities. So while it may be hard to, calculate exactly what that change is going to be, just there likely will be some sort of reduction, in the future of those programs. So just some financial strategy here, next steps, really, like we talked about, maximizing the Rural Health Transformation Program and maximizing that funding opportunities, starting your planning there. As Paul mentioned, reviewing your cost reports. We really recommend a detailed cost report review to ensure your reimbursement is maximized. Charge masters, review and update those. We say pricing updates every year, a full charge master every 2 to 3 years. On some of your commercial contracts, you are, capped at a 2 to 3% increase every year. So if you're not doing that pricing update every year, you're falling further and further behind, on those commercial payers. So would definitely encourage you to do that every year. And then just auditing those payer contracts to make sure that you're getting paid what they said you were going to get paid, especially with the Medicare Advantage contracts. We have seen a lot of discrepancy there, especially for critical access hospitals, to make sure they're getting paid appropriately.
Yeah.
At the PPS rate.
Yeah, and the contracts that as more Medicare Advantage plans come into the market, making sure you're reviewing those contracts, because a lot of times they're sending the critical access hospital a contract that's more applicable for a PPS hospital. So if you sign that, you won't get paid appropriately. They'll be denying certain things. So just making sure that internally or externally you're reviewing those contracts to make sure you're basically supposed to be getting what Medicare pays, and making sure you're reviewing those contracts to make sure that happens.
Yep. And just some other, areas to make sure you're reviewing for optimization. I'd say the 340B drug pricing program, although, there's been a lot of difficulty with that program, it's still a really great opportunity for rural and critical access hospitals to take advantage of. Just a quick update there. So through this, the Consolidated Act that was just passed in early February, they did scrap that 340B pilot program that they introduced back in July of 2025. So that's scrapped, but they also are trying to find a new way to get that rebate model into place. So we expect that pressure will continue on that 340B program. And then the other big thing I wanted to point out is some provider enrollment changes. So there were some changes maybe 2 years ago that they changed that provider-based criteria to it used to be 15 miles or 35 miles for another hospital, the only secondary roads, but they basically changed that to a 2-lane road criteria. So if you have any non-provider based locations, making sure you've reviewed this new mileage requirement to see if that would qualify you for provider based. And then as well, so the CAA 2026 has changed to off-campus hospital outpatient departments. So essentially, if you do have any off-campus hospital outpatient departments, you're going to have to do a provider-based attestation for those locations. And you're going to have a unique NPI for all of those locations effective 1/1/28. So definitely some big changes that came out from an enrollment perspective with that CAA 2026 legislation. We have one more slide, which is just, again, I think more strategy and information. Things that we probably have hit on already, just a summary here of, taking advantage of technology, assessing your internal controls, making sure you're going through an effective budgeting program. And then also, of course, workforce retention, recruitment, and training development is always a key strategic item for rural healthcare facilities. So saying that, we are right on time. Look, it's 12:30, so I know we're not leaving a ton of time for questions. But I think we may have one here in chat. So that question is, does the nonprofit for the Microsoft program require a 501c3 status? I believe that it does, but I'm not for sure on that. So I definitely recommend that you can go out to that website, but if you can't find it, please let us know and we can ask our IT department here as well to clarify. If there's any other questions, please let us know. But like we said, you can always, email or call Paul or myself. And then make sure if you do want a CPE certificate, that you email us to obtain that.
We will be sending out slides. Okay.
Perfect. Thank you guys so much for attending.